Now I hand over this case to esteemed panelists for further discussion and enlighten us for what would be the provisional diagnosis. Thank you.
Sir, please, Dr. RCC and Dr. Pandey sir, please come inside with the case.
Okay. This is an interesting case in the sense that it has almost everything that you can imagine in medicine. It has got the background of an aged geriatric patient, 67. If I'm not wrong, it was 67. 67. Okay, and she already has an acute exacerbation of COPD, for which she is non-compliant in terms of treatment, and she's presenting with acute onset dyspnea. So the first probable impression for me, if I am in the ED or in the intensive care unit, would be that she's probably suffered an acute exacerbation of a COPD attack. But since the background of the patient and along with that, the age component, the type of dyspnea that she's having, the X-ray findings that are being shown, the CT scans and everything that's come up, I think I'll keep a probable diagnosis of both the cardiac as well as the chest components, that is the acute exacerbation, because these are two primary things. An acute onset dyspnea will strike me as the first initiation. So I must rule out a possibility whether there is an underlying cardiac element to this, an old lady presenting to an acute exacerbation of COPD. So that is how I'll catch on and move on in this case. So some of the things that have already been done, like the ECG, the chest X-ray, the BNP, the troponins, they form a part of the entire cascade if I want to rule out a cardiac element to this patient. So they are okay. But what I did not find in the entire case was X-ray will take 20 minutes to diagnose a patient of acute dyspnea. It will not be available for me on the bedside. My clinical status plus minus, my clinical acumen may not be really profound enough for a junior present standing in the, or actually our first year standing in the emergency. It may not be clinically sharp enough to understand some of these things. So what should I be doing if I have something like this? I may not be able to read an ECG. We call on my senior, sir, ECG आ गया, please बता दीजिए. तो उतनी देर में मुझे क्या करना चाहिए इस पेशेंट के लिए, दो तीन चीज़ें इंपॉर्टेंट हैं, मैं बस हाईलाइट करूँगा. एक्यूट एक्सैजर्बेशन COPD, ऑक्सीजन ज़्यादा नहीं देना है, जो हमें सबने सिखाया, ऑक्सीजन ज़्यादा नहीं देना है, टारगेट 88 और 92 ही है. तो पल्स ऑक्स लगा, इससे ऊपर ऑक्सीजन देने की चेष्टा नहीं करनी है. नेबुलाइज करना है, नेबुलाइज यूजुअली 2 से लेकर 6 लीटर के ऑक्सीजन ट्यूबिंग से नेबुलाइज करते हैं. तो भी एक्स्ट्रा ऑक्सीजन हो सकता है एक COPD एक्सैजर्बेशन वाले पेशेंट. आप समझ गए मेरी बात. आप नेबुलाइज कर रहे हैं, ऑक्सीजन लगा के नेबुलाइज कर रहे हैं, उतना ऑक्सीजन भी इन पेशेंट्स के लिए ज़्यादा हो सकता है, क्योंकि ये हाइपोक्सिक ड्राइव पर रहते हैं. जैसे ही आपने ऑक्सीजन सप्लाई किया, सैचुरेशन अप किया और ये CO2 नार्कोसिस में जाएंगे, अलर्ट पेशेंट कोमेटोज हो जाएगा आपके सामने. तो बी केयरफुल. अनकंट्रोल्ड ऑक्सीजन इन पेशेंट्स के लिए खतरनाक है. इमीडिएट केयर का कंपोनेंट अगर रूम एयर पे 90 है या इससे नीचे ऑक्सीजन गिर रहा है तो वेंचुअली मास्क यूज़ करना है. सिंपल मास्क की एडेप्टेबिलिटी इन पेशेंट्स के लिए नहीं बनी है. इट इज़ ऑलवेज अ कंट्रोल्ड ऑक्सीजन डिलीवरी, जो मैं अपने रेजिडेंट को ज़रूर सिखाऊंगा. एक COPD का पेशेंट अगर आपके पास आएगा तो क्या करना, ऑक्सीजन कंट्रोल, ठीक है, मॉनिटर सी, एक सिंपल एस्पेक्ट्स में नेबुलाइज करना है. सभी बताएंगे, सब लोग बताएंगे एक्यूट एक्सैजर्बेशन COPD को नेबुलाइज सावा या सामा या इंट्राकॉर्टिकोस्टेरॉइड्स का इंजेक्शन देना पड़ता है. शॉर्टर रहे तो बेटर, दैट इज द डिक्टम फॉर ऑल पेशेंट्स. अ शॉर्ट कोर्स इज ऑलवेज एडवाइजेबल फॉर दिस पेशेंट. वो हम सब करते हैं और करना भी. इसके अलावा जो मुझे अपने रेजिडेंट को मैं जो ये सिखाऊंगा, क्योंकि इसमें 2 कंपोनेंट आपने बताए, एक हार्ट का एलिमेंट है, एक लंग का एलिमेंट है. ऐसे कंफ्यूजन सिनेरियो में जहाँ मुझे 20 मिनट लगेगा एक एक्सरे की रिपोर्ट आने में, मैं नया डिवाइस यूज़ करूँगा, उसको लंग अल्ट्रासाउंड बोलते हैं. आजकल इस पूरे केस स्निपेट में कहीं पे भी उस लंग अल्ट्रासाउंड की एम्फेसिस के बारे में नहीं बताया गया. इमरजेंसीज और ICUs ये इसको नंबर 1 मोडालिटी मानते हैं इवेल्युएशन ऑफ कॉम्प्लेक्स पेशेंट्स लाइक दिस। तो मेरे रेजिडेंट को एक लंग अल्ट्रासाउंड पक्का पूरा आता है, उसको बताने के लिए कि ये CHF का पेशेंट है, कि ये पल्मोनरी एम्बोलिज्म का पेशेंट है, कि ये आने वाले दिनों में शॉक में जाने वाला पेशेंट है, कि ये एक निमोनिया का पेशेंट है, क्या ये मल्टीपल कंपोनेंट वाला पेशेंट है। ये सारी कला मैं 2 मिनट 3 मिनट के एक लंग अल्ट्रासाउंड से कर दूंगा। तो इस पूरे केस स्निपेट में जो मुझे नहीं दिखा वो है लंग अल्ट्रासाउंड। हवा है तो लंग देखेगी नहीं, लेकिन हम जो देख नहीं पाते वो ही आर्टिफैक्ट बनता है, उसी से डायग्नोसिस बन जाती है। इसको बोलते हैं ब्लू प्रोटोकॉल। आप लोग ऑनलाइन कभी भी जाइएगा, कुछ जो लोग इंटरेस्टेड है उसको रीड कर लें। ब्लू प्रोटोकॉल बोलते हैं। ये आपकी इंटरस्टिशियल लंग डिजीज, निमोनिया, COPD, CHF, पल्मोनरी एम्बोलिज्म को 2 मिनट में बता देगी। ये आपका पेशेंट कहाँ जा रहा है। BNP निकालना और भेजने में लगेगा आधा घंटा, प्रोपोनेंस जाने और आने में लगेंगे घंटा, चेस्ट एक्सरे आने में लगेगा 20 मिनट, ECG के टेक्नीशियन को बुलाना और अपनी समझ से उसको रीड करने में भी समय लगेगा। लंग अल्ट्रासाउंड 3 मिनट, CT भेज नहीं पाओगे, अनस्टेबल पेशेंट होगा, कभी CT रूम तक पहुंचेगा नहीं। लंग अल्ट्रासाउंड ये इस केस स्निपेट का गायब सिनेरियो सीन है, इसलिए मैं एम्फसाइज कर रहा हूँ। मेरा इमरजेंसी बिना इसके कभी नहीं चलेगा। ये नंबर 1 मोडालिटी है बेड साइड की। ठीक है, मैं इतना ही बोलूँगा इस केस स्निपेट के बारे में।
Okay, Pandey sir, please comment on this is the cardiovascular component with the lungs attacks.
Thank you, Dr. Swapnil and Dr. R.K. Singh. That this case has already been opened up. As Dr. Rajadhar was discussing that many of these acute exacerbation of COPD patients, they do have many comorbidities. So similar was the case with this patient also, that the patient have associated comorbidities of hypertension, diabetes, hypothyroidism, and the already existing patient of COPD. So all these 3-4 comorbidities of hypertension, diabetes, hypothyroidism, our thyroid levels were poorly controlled, our lipids level were not edible, but they were also there. All those factors has also aggravated whatever the cardiac conditions were there. Over and above, the patient was also having reduced GFR. The GFR was very low. The point which Dr. R.K. Singh has raised very well, that point of care devices like bedside ultrasound, same is the case with bedside echocardiography. Dr. Swapnil has already told about this patient that the patient heart function was normal. But he didn't mention, and we all know that there are conditions which are called as HFpEF, heart failure with preserved ejection fraction, and they are very, very common in this group of patients, those who are hypertensive, diabetic. So whenever we look for, we always look for LV contractility and ejection fraction in these patients, but we have to look for their mitral regurgitation, their tricuspid regurgitation, their PA pressure also. That PA pressure can be decided bedside by just doing a bedside echocardiogram. You can see what is the PA pressure by measuring the TR-jet. So in the same way you are measuring the lung ultrasound and seeing the condition of lung, which CT has revealed in this patient that the patient has got bilateral pleural effusion more toward the left side compared to the right side. So the patient is volume overloaded. The reason is possibly the patient might have a heart failure with preserved ejection fraction. Etiologies are hypertension, diabetes, chronic kidney disease. Patient also had some rise in CPK and troponin, which might probably say that patient had some acute cardiac injury as well. See, many times you find troponins are falsely elevated in patients of acute kidney injury, so they may have a mild rise in their troponin levels. BNP was also high, but we need to have, if you get an anti-pro-BNP level, that's best to diagnose in these patients. BNP levels are a little high in this case, around 149 or so, but that's not too high, suggestive that patient is having a very significant heart failure. So the symptoms of the acute symptoms or acute attack in this patient is not completely because of heart failure only, there is something else. So So probably the heart failure has precipitated due to all these circumstances, or and the patient has an acute exacerbation of COPD and needs management for that. Simultaneously, we need to give IV diuretic this patient because patient is already volume overloaded, patient has got a low GFR. We need to take care of the respiratory part, as Dr. R.K. Singh has already suggested for this patient. We need to take care of closely monitor the patient's creatinine level and output because the patient's creatinine is recently found to be raised and already known patient of hypertension and diabetes for a long time. TSH is high, the patient is on supplemental Radisson level. So all these problems suggest that probably the patient has got some acute lung injury because of acute exacerbation of COPD, as well as heart failure with preserved ejection fraction, and that is very commonly seen in these group of patients. We do have management of these patients are basically the symptom related and management of the etiology itself. In this patient, we need to give them some sort of IV diuretic, reduce their volume status, reduce the volume intake, monitor their the intake output, as well as also put them on prophylactic anti-anginal medication. If the patient has got a higher troponin levels, probably there may be many times what happens that the ECG changes may not be there immediately. You need to do a serial ECGs every 8 hourly. You need to do serial troponin levels 8 hourly or 12 hourly to see is there any rise in troponin levels from first level to the second level. So that may suggest that probably the patient might have some acute cardiac injury as well. So that has to be taken care of. Serial monitoring of cardiac enzymes, serial monitoring of troponins, has to be serial monitoring of ECGs are required in these patients. We need to give them, these patients, also prophylactic subcutaneous heparin therapy, as these patients are very prone to have developed DVT, and in an acute critical care setting like these patients are prone to develop pulmonary embolism as well because of DVT, and those DVTs are many times silent, and the patient is immobile. So that part you have to take care of. You have to manage the patient's blood sugar level, very strictly to keep the mortality level high and to keep the mortality low, because we all know that acute critical care setting, the management of blood sugar levels causes a significant drop in the mortality levels. So this patient requires all these 3-4 managements and needs to be closely monitored. This patient has already some amount of acute lung attack, as well as the cardiac part is also there, and they have got plenty of other comorbidities which needs to be managed.
I'll just add something. सर ने काफ़ी सारी चीज़ों को बता दिया, ऑक्सीजन की डिलीवरी के बारे में, वेंचुरी मास्किंग, आपका फर्स्ट एबीजी दिखता है, उसमें ऑलरेडी ये पेशेंट हाइपरवेंटिलेट कर रहा है, यानी इसको किसी तरीके का आपको रेस्पिरेटरी सपोर्ट देना पड़ेगा. तो ऑप्टिमाइजेशन ऑफ थेरेपी जब तक चल रहा है, और अगर ये बैकग्राउंड में ऑलरेडी COPD का पेशेंट है और ये घर पे भी बाईपैप थेरेपी लेता है रात में, इसका मतलब आपकी फॉर्म ऑफ थेरेपी नेबुलाइजेशन के इमीडिएटली बाद एक बाईपैप फॉर्म ऑफ थेरेपी ज़रूर आएगी अगर ये पेशेंट कॉन्शियस, अलर्ट और रिस्पॉन्सिव है, कि सपोर्ट करने के लिए इसके ब्रीदिंग पैटर्न को, दोनों चीज़ों में हेल्प करेगी, लंग्स के लिए भी और हार्ट के लिए भी, क्योंकि पॉजिटिव प्रेशर जब देते हैं तो एल्वेलाइज ओपन अप करते हैं, जो फ्लडेड लंग्स होंगे वो ओपन अप होने की वजह से एल्वेलाई का हाई ऑक्सीजनेशन और CO2 एक्सचेंज को कॉम्प्रोमाइज़ नहीं होने देगा अगर आप पॉजिटिव प्रेशर देते हैं. हार्ट फेलियर में भी पॉजिटिव प्रेशर हेल्प करता है, क्योंकि पॉजिटिव प्रेशर देने से आफ्टर लोड जो होता है कम होता है, लेफ्ट वेंट्रिकल का आफ्टर लोड कम होता है. इसलिए MI बैकग्राउंड के पेशेंट्स में या CHF के बैकग्राउंड के पेशेंट्स में बाईपैप पॉजिटिव प्रेशर से लेफ्ट वेंट्रिकल आउटफ्लो ट्रैक का प्रेशर कम होता है, इसलिए आराम से हार्ट फ्लो आउट करेगा. ठीक है, इसलिए CHF के पेशेंट्स में बाईपैप रिकमेंडेड फॉर्म ऑफ थेरेपी है अगर आपको सपोर्ट करना है. यहाँ पे डुअल है तो दोनों तरह से फायदा करेगा, लंग्स के लिए तो कर ही रहा है, लेकिन बाईपैप आपके CHF वाले पेशेंट में भी हेल्प करेगा. बाकी कंजर्वेटिव थेरेपी जैसे सर ने बताया वो सब आपको करना है.
Thank you, sir. Dr. Rajiv, sir, please comment on this case.
But to my understanding, what is the then after the management is over, but I would like to know what is the cause of Because as somebody said that COPD, but history is not very clear about the COPD, that is one issue. And then in X-ray and CT, I am seeing that there is a bilateral effusion and there is a precardial effusion, also I understand. So, and she is very obese, I think 35 is the BMI, and whether obstructive sleep apnea was also associated with that, that has to be, ultimately when the emergency and everything you are managed, probably we have to go on these things to find out what actually has caused this. It's simply a respiratory or cardiac failure or some definite diagnosis, something definite in the body is going to lead to all these problems. Fluid, I'm not sure whether it was transudate or exudate.
So transudate.
Transudate, so definitely it is focusing that cardiac element is definitely there. And pericardial effusion was tabbed.
Yes, yes, sir.
It was also transudate.
Yes, sir.
It was also transudate. So what is the combination? So there is a combination of lungs and heart. And what was the GBP? Whether she also has part pulmonale, swelling of feet were there.
Yes, bilateral feet edema was there.
So the might be. So all this is culminated, but what I am not able to understand, what would be the ultimately you have to diagnose what these things are causing. So that is my, otherwise every aspect of the acute management has been very well discussed by these.
I think there are multiple challenges because once you pass the first day in the ED or in the next day in the ICU, there will be a lot of things being done for this patient, including lines, including procedures, including ultrasonography, including repeated nebulizations, IV steroid, short course of antibiotics based on your antibiogram of your local hospital or whatever, and a short course of antibiotic will definitely be there. Heparin, as was told by sir, low molecular weight heparin will definitely be there. She's already on aspirin with NST segment changes which are there, so that will definitely be there. But as the time goes, what sir is asking is, say she stays there for another 5-7 days, what is finally going to happen? Now, since there are diabetic element, there are hypertensive element, then there is a COPD element, then there is hypothyroidism as well. So I think I'll deal with each of them. Ultimately, this patient will go with polypharmacy. But at the heart of everything here starts is an acute exacerbation of a COPD. Probably she was non-compliant and therefore she's like this. There was an underlying element of the heart in terms of hypertension and diabetes, like a syndrome X presentation, which has got multiple features into this, and therefore she is physiologically decapacitated patient who has landed in your emergency. So with time, I think a lot of things have to be done for this patient. And it will not be a single diagnosis, it will be a huge physiological diagnosis.
I just want to add one more thing that Dr. Swapnil has already highlighted that this patient has a past history of myocardial infarction and the ECG was not completely normal. There is a loss of RWave from V1 to V4. There is a widening of little of a QRS. It suggests that probably I was not very well versed with the echo finding of this patient, saying that the patient, there is no resting regional wall motion abnormality and the patient doesn't have a normal ejection fraction. This doesn't goes with the ECG, which looks like there is a widening of QRS. Patient has a past history of myocardial infarction. They will be less likely to have a normal, this ECG is not normal. You see there's a loss of R wave. There's no progression of R wave from V1 to V2, V3, V4, which is called as a pseudo-myocardial infarction pattern. This is commonly seen with COPD patients as well, and Q wave-like things in 2-3 AVF. It may mimic like a COPD as well, but we need to know about the ejection fraction. And as this patient has a past history of myocardial infarction and raised troponins and CKNB, once the patient gets stabilized, you will just like to see the patient's coronary angiogram and we would like to know what is the coronary anatomy in this case, and proper management of patients' thyroid function is also required. The cause of pericardial effusion is possibly because of uncontrolled hypothyroidism.
Thank you, sir. Dr. J.K. Mishra, sir, please comment on this case.
Thank you, Dr. Pathak. I congratulate Dr. Swapnil for this excellent case presentation. It is a real case presentation which we need in such type of gatherings. Second point is that Dr. Singh, Dr. Pathak, Dr. Pandey and our teacher, Dr. Radisson sir has told each and every point about the case. What I want to say, that most important point which we should take from this discussion is the bedside practice. The learning and the knowledge and the facility of bedside ultrasound in the diagnosis and management. So big, so accurate, nothing can be better than this. Another point is that each and everything has been discussed. It looks very simple in the discussion, but I can guarantee that it is very difficult to manage this patient, and nobody can guess what will be the prognosis of this patient. It is a multi-organ system failure. No one person can manage this patient. We need all these specialists: diabetes, cardiology, chest physician. She may go in renal failure and she will go differently. Definitely, if you keep this patient in the ICU, there will be hospital required infection. There is 100% guarantee that if we put this patient on the ventilator, she will be infected hospital. Therefore, it is a very excellent. I congratulate Dr. Pathak as well as Dr. Swapnil, and I have great thanks for all my panelists. They are all my seniors. They are excellent people in their fields. And Dr. Rajendra Prasad sir is our teacher, great teacher. And I am fortunate. I am very, very much thankful from the core of my heart for inviting me here and for giving me opportunity to accompany such type of excellent clinicians at the system. Thank you so much. Thank you so much.
Thank you, sir. Thank you, sir. Dr. Radisson, sir, COPD management in this case, how we manage the patients in ICU situation in comments?
I think Dr. Singh has enough dealt with the part of the acute exacerbation of the southern, you can say, lung attack in the terms. He has covered most of the point. I think nothing is to be added.
One important thing about this case that the patient is overweight, morbid obesity, more than 110 kg weight, and one important thing is that the cases are very high. The cases are massive. Is there any comments, Dr. Abhijani sir?
Something may be linked with RI, maybe by pericardial. Can you please repeat the question?
Patient is overweight, so morbid obesity.
You are talking about another patient or same patient?
About this patient is overweight, morbid obesity, is high register thyroid test was very high. As a COPD part, how we can manage this patient?
I think it is just having a contributory factor, and maximum we can do something is what Dr. R.K. Singh has mentioned, that we need to add some non-invasive ventilatory strategy to that, and apart from that we manage hypothyroidism by medicine. I don't think anything extra.
स्टार्ट की बाईपैप तो आपने लगा दिया, लेकिन बाईपैप लगाने के आधे घंटे से 1 घंटे बाद उसको रीअसेस करना है, whether it is helping your patient. It's called the first hurdle and the second hurdle. So वो चेंज आ रहा है कि नहीं आ रहा है, pH में फर्क हो रहा है कि नहीं हो रहा है, CO2 बेटर हो रहा है कि नहीं हो रहा है, ऑक्सीजनेशन इम्प्रूव हो रहा है कि नहीं, क्लिनिकली पेशेंट स्टेबल लग रहा है कि नहीं लग रहा है। ये सारे पैरामीटर्स डिसाइड करते हैं कि इसको बाईपैप पे ही रखना है या इसको, अगर ये फेल हो रहा है विद इन 1 आवर ऑफ दिस थेरेपी, कि इसको इंट्यूबेशन की तरफ लेके जाना है। तो वो पूरे फिक्स क्राइटेरिया है। एंड वंस इंट्यूबेटेड, डिफिकल्ट पेशेंट, ओबीस है, डिफिकल्टी भी आएगी, वो सारा अरेंजमेंट, एंड देन फिर तो आईसीयू की पूरी कहानी शुरू हो जाएगी आफ्टर द इंट्यूबेशन ऑफ दिस पेशेंट। सो यू हैव टू हैव द आइडिया कि ये फर्स्ट हडल क्या है, सेकेंड हडल क्या है बाईपैप लगाने में, उसको कब लगाना है, किस मरीज पे नहीं लगाना है, ये ज़्यादा जरूरी है। लगाना तो सब जानते हैं, लेकिन किस पे नहीं लगाना है ये जानना बहुत जरूरी है। बेहोश पेशेंट पे, कार्डियक अरेस्टेड पेशेंट पे, हीमोडायनामिक अनस्टेबल पेशेंट पे, ऑल्टर्ड सेंसोरियम वाले पेशेंट पे बिल्कुल बाईपैप नहीं लगाना है। ये मैं जानता हूँ पल्मोनोलॉजिस्ट को आदत है कि बाईपैप सब पे लगाना है सीओपीडी में। ये आइडिया ठीक बिल्कुल नहीं है। अभी मैंने बताया 5 चीजें जहाँ नहीं लगाना है, चाहे सीओपीडी क्यों ना हो। Altered sensorium, cardiac arrested patient, unstable patient, altered sensorium, airways unprotected. Do not put this patient on BiPAP. He is a definite patient for intubation. pH less than 7.25. Be very careful. ठीक है, अगर आपने लगा भी दिया तो आधे घंटे के अंदर दोबारा चेक करना जरूरी है कि BiPAP से इसको एडवांटेज है कि कोई फायदा नहीं है, कि इसको इंट्यूबेट करना है। ये जानना जरूरी है। तो बाईपैप लगा के भागना नहीं है। बाईपैप लेबर इंटेंसिव स्ट्रेटेजी है, इंट्यूबेशन कम इंटेंसिव है एक्चुअली में। बाईपैप लगा के आप भाग नहीं पाओगे उस मरीज से 1 घंटा 2 घंटे तक, लेकिन इंट्यूबेट करके मैं आधे घंटे में निकल जाऊंगा, क्योंकि मैं उतने देर में उसको स्टेबल कर दूँगा। बाईपैप वाला मरीज जो इंट्यूबेट होने वाला है, वो जानने के लिए मुझे बेड साइड कम से कम 1 घंटा खड़ा रहना पड़ेगा, और पीछे इंट्यूबेशन की सारी ट्रॉली अलर्ट पे लगानी पड़ेगी। यानी मेरी नर्स भी फंस गई, मेरा वार्ड में अटेंडेंट भी फंस गया, मैं भी फंस गया, मैं जा नहीं पाऊंगा बाईपैप लगा के उस पेशेंट को। तो इट इज अ लेबर इंटेंसिव स्ट्रेटेजी, प्लीज अंडरस्टैंड दिस।
One comments from the Dr. A.K. Pandey sir. This is the case of the bone attack. There is a cardiovascular manifestation of COPD.